My name is Tahira Charles. I want to welcome you to the final installment of our webinar series. For those of you who have been with us from the very first one 2 years ago, thank you for continuing on this journey with us. For those of you who are new to our webinar series, we hope our presentation helps you to learn more about the work that we, as future speech and language pathologists, will be doing in the very near future. Today, my fellow classmates and I will be presenting to you information on the topic of fluency disorders. Firstly, I would like to introduce my 4 classmates who will be presenting alongside me today. They are Kimberly Jack, Dominique Edwards, Monique Pockeren, and Priya Samuel. Today's webinar agenda will include information on the MASLP program, an in-depth look at what fluency disorders are, including the different types and their common signs and symptoms, how and why SLPs are the experts on these disorders, how fluency disorders are diagnosed, what someone can expect during an evaluation, what someone can expect during intervention, some tips for home, school, and work, some frequently asked questions about fluency disorders, and finally, a Q&A segment where we allow you, our audience, to ask any questions related to fluency disorders. The Master of Arts in Speech and Language Pathology is a professional training program aimed at equipping fully functional speech and language pathologists. Some of its main objectives are to service the Caribbean region with an intellectual and professional capacity in this area, to educate the public as to support which can be provided to people with speech, language, and learning disabilities, a service we are providing by having these series of webinars over the past 2 years, to provide screening for the entire school-age population, as well as for adults with communication and swallowing disorders, and to provide assessment and follow-up services for the same population. The program targets persons with an undergraduate certificate in speech and language pathology or equivalent who wish to become professional speech and language pathologists. The program is completed in 3 years part-time, and some of our courses include oral rehabilitation, augmentative and alternative communication, fluency disorders, articulation and phonological disorders, voice and resonance disorders, and aphasia and related disorders. So I now pass you on to my classmate, Dominique, who will talk to us about fluency disorders, including a definition and description of the disorder.
Thank you, Tahira. Good day, everyone, and thank you for coming to our talk. Now I will go on to define and describe these fluency disorders. The American Speech and Hearing Association, also known as ASHA, defines a fluency disorder as an interruption of speaking characterized as atypical rate, rhythm, and disfluencies, which may also be accompanied by excessive tension, speaking avoidance, struggle behaviors, and secondary mannerisms. We often refer to these disorders as disfluencies, and they have 2 distinct categories. These are stuttering and cluttering. Stuttering, the fluency disorder most commonly known to the general public, is an interruption in the flow of speaking characterized by specific types of disfluencies. These include repetitions of sounds, syllables, and monosyllabic words. For example, look at the baby, or let's go out, 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 out. Prolongations of consonants when not in use for emphasis. So someone saying sometimes is a stutter, but yes, it's for emphasis. Blocks. These are the inaudible or silent fixation or inability to initiate sounds. They sound similar to can we or go. Stuttering affects the rate and rhythm of one's speech. This can lead to negative reactions to speaking, avoidance behaviors, where the person avoids certain sounds, words, people, or situations that involve speaking altogether. Escape behaviors, such as secondary mannerisms, eye blinking, head nodding, and any other movements of the extremities, body, or face while stuttering, and physical tension. Sometimes the tension is so strong that you can actually see the person's neck, shoulders, jaw tensing, and the muscles pulling. Children and adults who stutter also frequently experience psychological, emotional, social, and functional consequences from their stuttering. This includes social anxiety, a sense of loss of control, and negative thoughts or feelings about themselves and their ability to communicate. Cluttering is another fluency disorder. This is characterized by a perceived rapid and or irregular speech rate, atypical pauses, maze behaviors, pragmatic issues, decreased awareness of fluency problems or moments of disfluency, excessive disfluencies, collapsing or omitting syllables, and language formulation issues, which result in breakdowns in speech clarity and or fluency. An individual may exhibit pure cluttering or cluttering with stuttering. Their breakdowns in fluency and clarity can result from atypical pauses within sentences that are not expected syntactically. This looks like, I will go to the store and buy the apples. They can experience deletion and or collapsing of syllables or watch television. Excessive levels of typical disfluencies, so they'll have revisions and interjections, but to a point where it makes their speech almost indistinguishable. Maze behaviors or frequent topic shifting. I need to go to the, I outer cheese, and I ran out of cheese and bread the other day while making sandwiches. So now outer cheese and all I have is peanut butter, so I need to go to the store. And or they can engage in the omission of word endings. Turn the television off. Unlike persons who stutter, persons who clutter are not aware of their communication breakdowns and as such make no attempts to rectify them during interactions, which may heavily impact their ability to interact with others socially and be understood when communicating. So how do we help? What is the role of the speech-language pathologist in all of this? Speech-language pathologists play a central role in the screening, assessment, diagnosis, and treatment of fluency disorders. Some appropriate roles for SLPs include the following: providing prevention information, educating other professionals, screening of communication when a fluency disorder is suspected, understanding that awareness and concern about stuttering may vary across individuals and cultures, and using that information to conduct a culturally and linguistically relevant comprehensive assessment. Differentially diagnosing fluency disorders from disfluencies stemming from language encoding difficulties such as language delay or secondary language learning. Referring individuals to other professionals to rule out other conditions and facilitate access to comprehensive services, as well as developing a culturally and linguistically relevant intervention plan to assist individuals achieve more fluent speech and self-acceptance of this fluency. Speech-language pathologists also recommend related services when necessary, assist children who stutter in dealing with teasing and bullying, counsel individuals with fluency disorders, and consult and collaborate with individuals with fluency disorders, their families, professionals dealing with them, their peers, and other invested parties to identify priorities and build consensus on an intervention plan focused on functional outcomes. Fluency disorders range in complexity, and speech-language pathologists may treat the client alone or may be part of a wider team of professionals working together. At the end, the goal is to treat the client's disfluencies and any compounding causes to assist them with a better quality of life. Now, Priya will take us through diagnosis and what one can expect. Thank you for your time.
Thank you, Dominique, and thank you all for tuning in. Now we will commence our discussion on how is it diagnosed. Individuals suspected of a fluency disorder are referred to a speech and language pathologist or SLP. During the evaluation, the SLP considers various factors that provide a holistic understanding of the individual's condition. According to the American Speech and Language Hearing Association, or ASHA, the following factors are observed alongside disfluencies: family history of fluency disorders, speech and language concerns, where the overall communication skills will be analyzed to determine if the fluency disorder is isolated or coexists with other speech and language issues. 3, self-perception of their fluency. This is the observation of their self-awareness. The individual might be asked to describe their fluency and how their self-perceived severity impacts their daily life. External reactions to the disfluency. This include positive or negative reactions to social feedback or support system that from those around them. Exhibition of physical tension or secondary behaviors, and difficulty in communication due to interruption in speech flow. Knowing that some of these factors are present is the basis for referral to an SLP. An SLP will perform a comprehensive assessment to identify and describe the following: impairments in body structure and function, which includes frequency, severity, behaviors, and tension, limitations in activity and participation. How does this affect the individual's interaction at school, work, home, or in social settings? Contextual factors that involve discussing the barriers or facilitators to successful communication. What to expect at an evaluation? Assessing fluency disorder is a complex process. When evaluating a client for fluency disorders, different factors are considered to determine whether the present problem is a disorder or a normal disfluency. For all fluency disorders, a case history and clinical interview must be completed. This is an important component of clinical assessment. Information from the case history shapes the assessment instruments administered according to Logan. It informs a clinician about the perception of the problem onset, changes over time, and any history of communication disorders. The case history and interview also collect information on developmental history, medical background, social background, and school or work activities. The case history and questions asked in the interview would be tailored to meet the client needs and can be adapted for use with different age, group, cultures, etc. Furthermore, depending on the age of the child, for example, an interview can be done with individuals in the respective social life or setting. For example, interviewing a school-age child, teachers to get information about their fluency in school. Speech samples. Speech samples are one of the most important procedures in any fluency evaluation. The speech sample will assist the SLP in identifying frequency of disfluencies, which is how many times did the individual experience disfluent events in the speech sample task, the type of disfluencies. It would look at repetition, blocks, interjections, prolongations, etc. Severity, mild, can be mild, moderate, moderate to severe, or severe. Secondary behavior, which will be discussed further in the presentation. Stuttering is variable, and therefore speech samples should be gathered from different settings and throughout different activities. Samples are usually obtained from oral reading, dialogues, and monologues. Some settings that speech sample can be collected from a school, home, clinical room, and the work environment. Assessment of stuttering. The main assessment used in the evaluation is the SSI-4, or the Stuttering Severity Index 4. The SLP will use their clinical judgment when conducting the task of the SSI-4. The SSI-4 is designed to assist in rating the severity with which a person stutters. It includes fluency-related norms which compare the client's performance to the age group of other individuals that stutter. It is divided into 3 age groups: preschool, school age, and adult. The SSI-4 uses specific materials and procedures to obtain a speech sample. It elicits 2 types of speech samples: oral reading and spontaneous speaking, which are facilitated through pictures, narratives, conversation, and reading passages. These speech samples are analyzed and assess the client's frequency, duration, and physical concomitants. Assessing frequency. This refers to how often stuttering events occur in a speech sample. The frequency of stuttering is commonly reported as the percentage of syllables stuttered in the SSI-4, although some uses the percentage of words stuttered. For example, where is my basketball is counted as 1 syllable repetition or 1 stutter. Assessing duration. The SSI-4 duration refers to the length of time the stuttering events last. This component assesses the average length of 3 of the longest stuttering events in a speech sample. It provides information on how stuttering can interfere with communication. The longer the event, the more disfluent and disjointed the message become. Assessing physical concomitants. In the SSI-4, physical concomitants refer to secondary behaviors or physical movements that accompany stuttering. It is rated on a scale of 0 to 5, where 0 indicates no noticeable physical concomitants, and 5 indicates severe and very distracting behaviors to the conversation partner and the individual. The behaviors include distracting sounds, facial grimaces, head movements, and movement of the upper and lower extremities. These 3 components, duration, frequency, and physical concomitants, are combined to provide the severity. The SSI-4 considers not only the speech behavior disruptions themselves, but also the associated physical behaviors that can impact communication. Assessing feelings and attitudes. The SLP will also observe the feelings and attitudes the individual have towards their fluency disorder and the impact. The feelings or emotions of individuals who stutter, as well as their beliefs and attitude about themselves, communication, and stuttering are all components of stuttering according to Guitar. The experience of stuttering can have associated physiological responses and can impact their behavior and how they respond to certain people or settings. This individual may be judged, criticized, or bullied because of their disfluency, and may develop negative feelings and attitudes or even avoidance behaviors. On the flip side, they may not be affected by the disfluency due to having the correct support system. Assessing feelings and attitudes usually involves self-report questionnaires and scales. The following may be used: Kenneth-Shipley Communication Questionnaire. It has 14 true or false statements that explore the individual behavioral responses, attitudes, and belief on the impact on daily life. The Kitty Cat or Communication Attitude Test for preschool and kindergarten children who stutter. It consists of 12 yes or no questions that evaluates young children's attitudes towards their speech. An example of the question is, do you think that mom and dad like the way you talk? The questions are asked in a play-based environment. The higher the score, the more negative the attitude. The behavior assessment battery for school-age children who stutter, which contains the speech situation checklist that evaluates a child's reactions to a range of situations, as well as the behavioral checklist, which assesses a child's coping response to their disfluency. OASES, or Overall Assessment of the Speaker's Experience of Stuttering, is a questionnaire designed to assess the impact of stuttering on a person's life. It focuses on feelings about stuttering, reaction to stuttering, communication in daily situations, and the extent to which stuttering interferes with daily life. It can be used for ages 7 to 12, adolescents, and adults. Differential diagnosis. We will now discuss differential diagnosis. Stuttering can coexist with stuttering, but can present on its own. Stuttering affects 4 aspects of communication, which are articulation, language, voice, and fluency. Thus, assessment will include these areas. The type of assessment that can be done are articulation testing, spontaneous conversation sample, oral reading. This will reduce language formulation difficulties, but may have presence of syllables omission, rapid speech rate, etc. Storytelling for language assessment, which will look at the structure, cohesion, intelligibility, pausing, and other factors will be observed. Neurogenic stuttering. This arises due to a neurological injury such as a stroke or traumatic brain injury. The brain has difficulty coordinating the different brain regions involved in speaking, which results in problems in production of clear, fluent speech. This is also called an acquired fluency disorder. Assessment can involve case history, including medical history, speech and language evaluation for analysis of speech patterns, and spontaneous speech samples. Psychogenic stuttering appears to emerge from individuals who have experienced psychological or emotional trauma. Assessment includes case history, analysis of speech patterns through structured tasks and spontaneous speech samples, observation of fluency in different emotional states and contexts through speech samples or interviews. The ABC. We have been given a lot of information to process thus far, so the ABC model shall be used to summarize the evaluation portion. The ABC model is a useful framework in the evaluation of fluency disorders, encompassing the aspects of stuttering or cluttering. So affective, A, deals with feeling and emotions associated with fluency disorder and is evaluated through case history, interviews, and self-report scales. B, or behavioral, involves the speech behaviors, including the frequency, duration, and type of disfluencies and secondary behaviors. It is evaluated through speech sample analysis and using the SSI-4. C, or cognitive component, examines the individual's thoughts and beliefs about their speech and their stuttering or cluttering, and is assessed through interviews. I will now pass you on to my colleague, Kimberly, who will talk about the intervention aspect.
Thank you, Priya. What to expect during intervention for fluency disorders, starting with stuttering. Firstly, clients are to expect a person and family-centered practice. This involves a collaborative approach to planning, delivery, and evaluation of clinical services. It is grounded in a mutually beneficial partnership among individuals served, families, and the clinician. Each party is equally important to the relationship, and each party respects the knowledge, skills, and experiences that the others have to share. Motivational interviewing is also a person-centered approach that can be used in developing functional goals and enhancing readiness for change. It incorporates techniques such as open-ended questions, feedback, reflective listening, affirmations, and summarizing to resolve resistance to therapy. And this is because after an evaluation by a speech-language pathologist, the SLP, the client, and/or the parents or family work together to decide on the best treatment, including goals for the client. This will vary with the clinician's beliefs, the client's age, and the developmental and treatment level of his or her stuttering. Because problems and needs vary from person to person, one method or a combination of methods that may work for one person may not work well for another. There are many different methods available to treat children and adults who stutter. Nonetheless, it is still possible to describe most of the goals that clinicians have for clients who stutter and to suggest which goals are likely to be paramount for which level. Treatment goals. Most individuals who stutter demonstrate both noticeable disfluency and negative life impact. When developing treatment goals, the clinician takes a holistic approach and considers the extent to which stuttering affects the individual's entire communication experience. However, keeping in mind treatment is a person and family-centered practice, the clinician is not the only one who determines the goals of treatment. Clinicians, clients, and their families have an important role to play in choosing goals that are paramount for them. Ongoing discussions between clinicians and clients about treatment goals strengthens the client's motivation to achieve them and enhance the relationship between clients and clinician. The selections of goals presented: 1. Increasing effective and efficient communication, increasing acceptance and openness with stuttering, reducing secondary behaviors and minimizing avoidances, improving social communication, increasing self-confidence and self-efficacy, managing bullying effectively, and minimizing the adverse impact of stuttering are overall general goals for stuttering therapy and would be tailored across the different age groups. Preschool age children intervention for ages 2 to 3.5 years. Parent and family involvement in the treatment process is key. Intervention at this age involves a partnership between the SLP and parents. Treatment used for this age group should be an indirect approach. An indirect approach takes the form of parent training and will focus on counseling families about how to make changes in their own speech and how to make changes in their child's environment to assist with their child's speech fluency. All of these children between the ages of 2 and 3.5 years have been stuttering for less than a year, and many have the likelihood for a natural recovery. Therefore, everything must be done to avoid interfering with the natural recovery and instead to facilitate it. It is also important to realize that most children between ages 2 to 3.5 years aren't cognitively ready or cannot follow instructions to learn from direct treatment on how to change their stuttering. The main focus of treatment is on the behaviors of the family members, the family's interaction styles, including both speech and non-speech behaviors, and others who interact frequently with the child. Consequently, the child's feelings and attitudes are not dealt with directly. However, as a family and clinician monitor the child's fluency, they try to ensure that he or she is not developing any negative attitudes about speaking or about their disfluencies. Some indirect approaches that families can do to facilitate natural recovery at home are: 1. Listening time. All children benefit from feeling that what they have to say is important. 2. Slow rate. Family members may reduce their conversational rate of speech to a slow, soothing style. Pauses. The pace of conversation can be kept appropriately slow if the speaker pauses 1 to 2 seconds before starting to talk. Positive comments. Make many positive and accepting comments about what your child is saying and doing. 5. Fewer questions. It is natural to ask a child many questions in order to encourage him or her to learn new things and to display that knowledge. However, this makes some children feel under the gun. So it may be a good idea to decrease demanding questions and instructions. preschool age children ages 3.5 to 6 years. At this age, stuttering may have spread or become more prevalent and more consistently present. These children become aware of their stuttering, and although they have little shame of it, they do not dread or fear speaking situations. However, at this stage, a direct approach can be introduced. A direct approach focuses on changing the child's speech, attitudes, and beliefs in order to manage stuttering or facilitate fluency. Direct treatment approaches may include speech modification, for example, reducing the rate of speech and prolonging or stretching syllables, and stuttering modification strategies, for example, modifying a stuttered word or pulling out of a stuttered word to reduce disfluency rate, physical tension, and secondary behaviors. The main focus is reducing negative reactions to stuttering and to reduce stuttering events and tensions in speaking situations. At this stage, parents are still involved as young children may or may not verbalize their reactions or state how they feel about stuttering. In therapy, the clinician looks for reactions such as avoidance of words or speaking situation, increased physical tension and or secondary behaviors such as head nodding, leg tapping, fidgeting with hands or eye blinking, etc., reduce utterance length or slight changes in pitch or loudness during stuttering episodes. While at home, the parents also look for these behaviors to share with the clinicians. The child at this age has only occasional frustration and not much concern about talking or avoidances of stuttering. The feelings and attitudes of these children are, however, influenced by the family. Another direct approach with a high success rate used with this age group is the LIDCO program. It is a behavioral treatment that is done by parents. It is evidence-based by clinicians and researchers for preschool age children. It has 2 stages. The moments of unambiguous stuttering are used to determine severity ratings to track progress. The goal is no stuttering. Parents complete severity scale daily, reflecting his or her judgment of the child's stuttering severity that day. Using this program, the SLP teaches the parent to deliver treatment to the child and to use a 10-point Likert scale to measure the severity of the child's stuttering in his or her everyday environment. There are 2 stages to the program. In stage 1, the parent and child meet with the SLP on a weekly basis for the parent to deliver treatment in the child's environment daily. The SLP measures the percentage of syllables that are stuttered, and the parent monitors the child's speech using the 10-point scale, where 1 represents the absence of stuttering and 10 represents extremely severe stuttering. Once the child's stuttering decreases, stage 2 or the maintenance stage begins. This is where the parent and the child attend sessions less frequently and treatment is decreased. Intervention for school-age children aged 7 to 12, teens and adults. These are grouped together because they involve working on the affective, behavioral, and cognitive components, or the ABCs, of treating fluency disorders. The affective deals with emotions or the feelings and attitudes towards stuttering. B, which is the behavioral, deals with the secondary behaviors and disfluency types and tension. And C deals with the cognitive, which is the thoughts about stuttering. At this age, these children are beginning to avoid certain words and speaking situations. As they grow, disfluent behaviors become more difficult. Thus, the fear of speaking and being judged, anxiety, shame, and resulting avoidance increases. So it is important to eliminate or reduce these avoidances in therapy. For teens and adults, these individuals would have already developed negative experiences about speaking situations and listener reactions. Teens and adults, stuttering would involve more core behaviors that is repetitions, blocks, and prolongations, and secondary behaviors, physical tensions, and which are physical tension and associated behaviors, emotions and awareness, and cognitions, which are the negative thoughts about stuttering. Therefore, treatment is most effective if it targets all of these areas. Intervention for school-age children, teens, and adults would encompass many goals, including unlearning negative behaviors, reducing the struggle to speak, and reducing disfluent speech and learning new suitable behaviors. Unlike treatment for preschool age stutterers, this therapy begins with a focus on stuttering behaviors that are first explored and then changed. Intervention also considers the different age ranges of the individuals, their unique needs, and the different speaking environments, such as in the classroom, in the community, or at work. Intervention is done incorporating the ABCs of treatment following these 4 stages of stuttering modification, starting at identification. These stages are still tailored to each individual, as well as there are special considerations for each age groups for intervention. So firstly, in therapy for persons who stutter, the clinician will start with identification, then desensitization. This deals with addressing fears and avoidances. In identification, the clinician will take time to have the person who stutters recognize and examine the core behaviors or secondary behaviors and feelings and attitudes associated with his or her individual nature of stuttering. This is done using oral reading or discussion, modeling stuttered behaviors, and self-observation. Desensitization, which are strategies that are done in order to help speakers carefully desensitize themselves to their fears about speaking and stuttering by facing those fears in a structured, supportive environment, such as the therapy room, while listeners or with familiar listeners or the SLP alone. One desensitization activity is pseudo-stuttering, or what we call stuttering on purpose, in a different and increasingly more difficult situation, where the individual might fear the occurrence of real moments of stuttering. 2, modification, including fluency shaping techniques. These are strategies to help reduce stuttering events and physical tension. The person who stutters will learn modification strategies geared towards recognizing physical associated behaviors, for example, the eye twitching, blinking, head nodding and fidgeting, etc., locating the point of physical tension and struggle during the moments of disfluency, and also reducing the physical tension and struggle. By increasing the person who stutters awareness and self-monitoring skills, it will help to reduce the associated behaviors that interfere with speech, allowing them to modify moments of stuttering, reducing tension, causing smoother communication. These modification strategies include preparatory sets. This is where the speaker anticipates a moment of stuttering before it occurs and then uses stuttering modification strategies that the SLP will explain further in therapy to more effectively manage the moment of stuttering while producing the word. Then we have pullouts, which is during a stuttered word, the speaker slides out of the stuttered word to stutter smoothly through the word. Then we have cancellations, where after a stuttered word, the speaker pauses a few seconds to examine and rehearse the physical features of the stuttered word to produce an easy version of the stuttered word. The person who stutters will also learn different fluency shaping techniques. These are geared towards making changes to the timing and tension of speech production or altering the timing of pauses between syllables and words. These modifications are used regardless of whether a particular word is expected to be produced fluently. These fluency shaping techniques include easy onset. This is the gradual onset of voicing. light articulatory contact using easy articulatory postures, prolonging syllables or stretching each syllable in words or utterances, and rate control, slowing the overall rate of speech. Thirdly, we have stabilization. This includes transfer or generalization, which deals with the client's independence and establishing external supports in the client's environment. In stabilization, the person who stutters becomes self-aware and confident in monitoring his or her own stuttering behaviors. The clinician provides support for the client as independence is developed and therapy is gradually reduced. Generalization or transfer is also addressed during the stabilization phase. The client is able to use the techniques learned in therapy in a more natural context. The client is encouraged to face situations that were feared and avoided prior to therapy. For example, making a phone call, conversation with strangers. The clinician may give telephone assignments, shopping assignments, job interviews, or personalized tasks. So this is where the client is transferring what they would have learned in therapy to natural speaking context. The client is dismissed from therapy once he or she becomes more confident and feels that stuttering moments in everyday situations are manageable. And 4, maintenance. This deals with maintaining strategies learned from therapy. The strategies learned during therapy are maintained by the client during the stabilization phase and after dismissal. When the client feels recurring stuttering behaviors are a problem, it is encouraged to reiterate the phases of therapy with pseudo-stuttering or stuttering on purpose. Next, we have what to expect during cluttering intervention. Interestingly, persons who clutter are usually not aware of their problem and are often surprised when listeners don't understand them, and therefore they rarely seek treatment and are often referred by someone else. According to Asher, there is limited data on the age of the onset of cluttering. However, the age of onset of cluttering appears to be similar to that of stuttering. Individuals typically aren't diagnosed or do not start treatment until 8 years of age or into adolescent or adulthood. The best approach for cluttering intervention, as with stuttering, is individualized treatment. And this is because every person who clutters shows different cluttering speech characteristics. However, there is one main goal: to reduce the speaking rate, and several treatment strategies that can be applied to everyone. Lanouette, Myers, and St. Louis outline several cluttering therapy strategies that can be used in intervention. These include increasing the client's awareness of his speech rate and his ability to decrease the rate, improving linguistic skills, practicing pausing, increasing the client's knowledge and awareness of cluttering. Continuing on cluttering intervention, it can also involve fluency shaping techniques, excluding easy onset and continuous phonation, modification strategies, likened to that of pullouts and cancellations in stuttering therapy, over-articulation, overemphasizing multisyllabic words and word endings, and increasing awareness of when a communication breakdown occurs. This deals with having the client and clinician video record the client's best and worst speech and play these samples back to him or her to remind them of the range of their options. Just to expand more on these last points of cluttering intervention, quoting from the American Speech and Hearing Association on Fluency Disorders, subsection for cluttering treatment. Because a theory behind cluttering is that speakers are talking at a rate that is too fast for their systems to handle, techniques that help regulate speech rate, such as increased pausing, often are helpful. In fact, increasing pausing alone may increase speech fluency and intelligibility for those who clutter. However, fluency shaping techniques such as easy onset or continuous phonation may not be appropriate for treatment of cluttering. There has been some documentation of the use of stuttering modification strategies to help those who clutter. Such strategies include simulating a fast rate of speech and applying pausing and/or simulating over-articulated speech and applying increased emphasis to increase intelligibility. These simulations and applications of strategies might be most likened to cancellation and pull-out techniques used in stuttering. Other strategies for treating cluttering include the overemphasizing multisyllabic words and word endings, increasing awareness of the communication breakdown, and increasing self-regulation of rate and clarity of speech. End quote. This brings me to the end of what to expect in intervention, and I will now hand you over to Monique, who will take you through some helpful tips.
Thank you so much, Kimberly. So now that we've heard all about the evaluation and intervention of fluency disorders, you may be wondering, how can I help persons who stutter? Or if you're a person who stutters, how can I help myself outside the therapy room? It's time to delve briefly into some helpful tips. Let me start with adults and work my way back to the little ones. For those whose stuttering persisted into adulthood, breath control is of paramount importance. Deep breathing will help you to center and be in the present moment, as well as reduce any stress you may be holding on to. The best part is that you can always do this wherever you are. Take a moment, inhale through your mouth and exhale through your nose gently 10 times, holding on to your breath for a few seconds before releasing. Next tip is to slow it down. Speaking at a slower rate allows for more control of your speech. In a similar way, the pause and phrase strategy helps with slowing down and breath control. It is recommended that you practice pausing in the middle of phrases and sentences. For example, you can practice reading aloud and try inserting commas or dashes where you may naturally pause, as this will act as a visual reminder to slow down. Another great tip is to record your own voice talking or reading aloud, just on your phone, which is convenient as it may always be with you. This allows you to self-monitor through biofeedback. Get comfortable learning your own speech patterns and adjusting where you find necessary. In addition, keeping a personal journal can help you monitor your progress. And one of the most important tips is to practice in real-life social situations. For example, when next you're ordering food or talking in a meeting or simply delivering a presentation. Joining a support group for persons who stutter provides a safe space. Research has shown that being part of such a community is particularly beneficial for adults. I'm not certain, however, that there are any locally at this time, although starting one is a great idea, but there may be virtual options you can explore. Now for children who stutter, parental support is critical. What you say and do matters most to them. Providing that one-on-one time every day counts big. During play is best, where you follow their lead. This strategy allows your child to feel comfortable and have a sense of control of their environment for a while. So generally, you want to not interrupt your child when they're talking and in the middle of a stuttering event. In other words, do not finish their sentence. This simple act really helps to develop confidence in your child's speaking skills and can trickle over into other social situations, such as school, if they are unfortunately faced with challenges like bullying from peers or strangers. Pump them up with positive talk and self-image. What you can also do is model a relaxed and slower rate of speech by reducing your rate of speech during conversation with them. Talk at a slower and comfortable pace. Try pausing after every few words or so. Above all, stay positive. Positivity is the name of the game always. You can acknowledge their struggle, their frustration, and frame their response in a positive way. Example, that was a bit hard to say, but it's okay. Help them not stay in that negative space. Remember that stuttering is not a byproduct of laziness or carelessness, etc. In fact, children who stutter are likely trying harder than average to communicate effectively. In case you're wondering at what point should I seek out a professional such as a speech-language pathologist for help? Well, if you notice signs such as if the person avoids or withdraws from social situations. For adults, if the stutter develops after an acute event such as trauma or illness. If stuttering negatively impacts quality of life, for example, withdrawal from participation in preferred social activities. If the child's stuttering worsens and or persists over a few months, and if the child is over 3 years old, that is just beyond the typical period of a language burst, and his or her stuttering occurs consistently. So here are some helpful resources. Should you need to contact a speech-language pathologist, you can send an email to the Occupational Therapy and Speech-Language Therapy Board. They will provide you with a list of registered speech-language therapists working in Trinidad and Tobago. That address is otslpboard@gmail.com. It is also on the slide here and will be posted in the chat. Psychologists also play an important role when treating clients with fluency disorders due to its complex nature. Your speech-language pathologist can recommend or provide a referral if deemed necessary. And don't rule out the World Wide Web. Professional websites such as the Stuttering Foundation is a great educational and training resource. They offer materials such as handouts that are free to download, as well as YouTube videos. So we're going to tackle some frequently asked questions now. Some answers may be a recap of earlier material, but may provide helpful information to those of you who may have joined us late. I will read the questions all out first and then cover them one by one. 1, what causes stuttering? 2, is there a cure for stuttering? 3, why do I stutter on certain words? 4, how does speech therapy help stuttering? 5, what are some common misconceptions about stuttering? 6, what other professionals assist persons who stutter? And 7, how do I help someone who stutters? So question 1, what causes stuttering? This is still unknown. However, research suggests neurological underpinnings or brain structure differences in persons who stutter. There are studies on families that have pointed to hereditary factors, such as male children were at higher risk for developing stuttering than female children. And children who stuttered had far more stuttering relatives than did children who didn't stutter. Further, Bloodstein and Ratner, 2008, looked at children who were adopted and studied the impact of environmental influences as compared to genetics on persons or children who stutter. They found that a history of stuttering in the biological families was slightly more predictive of disorders in these children than was stuttering in the adoptive family. 2, is there a cure for stuttering? To date, there is no known cure for stuttering. However, focus can be placed on mitigation and management. Early intervention has been shown to help with recovery in children, referred to as natural or spontaneous recovery. That means if stuttering consistently occurs beyond age 3, speech therapy employing evidence-based strategies, such as the Lidcombe program that Kimberly spoke about earlier, helps reduce the risk of stuttering persisting into adulthood. 3, why do I stutter on certain words? Because stuttering is a complex disorder that involves the ABCs, affective, behavioral, and cognitive factors, some persons who stutter may have developed learned avoidance or escape behaviors, such as using another word or choosing a different situation due to difficulties or negative experiences related to the stuttering. That association can trigger certain feelings or attitudes and impact fluency when encountering certain sounds or words. Furthermore, some linguistic tasks that may require greater cognitive and/or linguistic demand can also have an impact on the sensory motor system, thereby increasing disfluency. Examples include reading out loud in small groups at school or oral presentations at or for work. 4. How does speech therapy help stuttering? Essentially, speech therapy targets the following. Some of this will be a recap as well from what was mentioned earlier. It tackles the ABCs of stuttering mentioned previously. Clients learn about stuttering and the speech mechanism. They also learn how to reduce the frequency of stuttering by building awareness of and learning how to decrease tension during moments of stuttering with different fluency shaping and stuttering modification techniques, such as easy onset, light contact, cancellations, and pullouts. Speech therapy also helps clients learn to decrease avoidant behaviors and improve their overall communication skills. Speech therapists can also help clients formulate personalized, long-term and short-term goals. Number 5, what are some common misconceptions about stuttering? Myth 1. People who stutter are not intelligent or less capable, when in reality, that is not the case. There is no link between stuttering and intelligence abilities. I think we just need to catch up on the slides there a bit. There we go. Thank you. So myth number 2, people who stutter need to slow down. In reality, it's not just about slowing down. People who stutter may need extra time to share their message due to the neurophysiological differences and other factors. Another myth is that stuttering should not be discussed in front of or with children who stutter. However, educating children about stuttering can actually help them improve their self-confidence and rather equip them with skills such as self-advocating, allowing them to be able to speak up for themselves and inform others about the condition, and which the effects of this can be far-reaching. It raises public awareness through education and can be very motivational to others like themselves who stutter. Question number 6. What other professionals assist persons who stutter? Treating a person with a fluency disorder often takes on a collaborative approach, and the type of professionals will depend, of course, on the age of the person. But generally, starting from young, there are professionals such as teachers who are well positioned to model appropriate communication for peers in the classroom, as well as educate others about stuttering. Psychologists can also be instrumental as they provide counseling that will address psychosocial effects of stuttering. And social workers can also help clients to realize their full potential by suggesting modifications to the environment that can best support the daily functioning of the person who stutters. For situations like neurogenic stuttering, collaborating with physicians and neurologists regarding pharmacological care is also important, as some medications can affect the frequency of stuttering events for persons with neurological disorders. And number 7, the last one, how do I help someone who stutters? This pertains to having conversations with persons who stutter. You want to first listen. Listen for the message, focus on the what of the message versus how it is being delivered. Be patient. It is best not to make remarks such as slow down, take a breath, or relax. Speech therapy will help persons who stutter develop these strategies on their own. Also, don't fill in their words or sentences or speak at a fast rate. Slow down your rate of speech, but not to the point of sounding unnatural. This promotes good communication all around. Simply, it puts a person who stutters more at ease. Lastly, use natural body cues or language such as eye contact. This small gesture can make a world of difference to a person who stutters and make them feel heard. Wait patiently and naturally until the person is finished communicating their message. Okay, so now that takes us to the end of the presentation today.